So when you practice English, as John has said, although we recognise that English is not your first language, the more that you can practice English amongst yourself to make you fluency.
So when we think about the two sets of cases now, what we're trying to gauge is that you can read a patient and you can explain things like informed consent. You can then collect records, you can diagnose what the problem is, you can formulate a treatment plan, and then you can think about how that treatment plan is going to cause you problems and how you might manage that treatment plan and take it forward. So we've got a spectrum of information going from the diagnostic to the mechanics, and there is some overlap in the middle. So the diagnostic cases will focus on that first phase. They will focus on using records to diagnose the problem, understand what the anchorage requirements are, and develop a treatment plan. Really good candidates will start to talk about their mechanics, and that's good. They're earning extra marks, but they've probably passed already. Poor candidates often struggle to get a valid plan. When we move across to the mechanics section, you've already got a plan. That's been decided for you. And now you're going to talk about what anchorage requirements there are now in the case and move forwards to talk in detail about the mechanics. So it then covers all of that information. So we're going to start by talking about the diagnostic part of the exam. This is certainly where you guys find the most stressful. You're under a timed pressure, and we understand that. Shaky pens, candidates coming through. We are the friendly college. We are here to look after you. Our staff are here to look after you. We understand that you will be nervous, and we will treat you that way. You are fellow professional colleagues. We don't treat you as subordinates. You are fellow colleagues, and very soon will be members of our college, we hope. So we will look after you where we can and relax you. You will have 4 cases, depending on where the diet is and depending on how many candidates we have. Sometimes they run back to back. For example, in Cairo this week, everybody did the first case, and then you're quarantined through. Now that can be difficult because everybody's stressed. Put in a room together, and putting a group of stressed people in a room together starts. So you've got to be aware that you will be quarantined. The security of our exam is paramount. To pass this exam, you have each got exactly the same cases coming through. So if somebody starts to share information around, that will be a real issue. Previously, people would bring their own cases, everybody would have a variety of different questions. It is much more structured now, and although the vivas may take slightly different directions depending on what you discuss, it is much more standardised. So because you have the same case, we have to get you through the case, quarantine you until everybody is seen that case. So within this, you'll have the patient history. Read the history. Okay, so quite a few people this week didn't read aspects of the history, and I'll come back to that. You'll have some extra-oral and some intra-oral photographs. You will not have study casts, but you will have a printout of the study casts. Okay, we'll come back to that in a moment. You will have appropriate radiographs. There may be additional radiographs that you think would be helpful in the case, but you should have enough to diagnose the major problems with that case. There isn't always a lateral cleft, but most of the time there is. Sometimes that's a discussion point. Okay, there wasn't a lateral cleft here. Would you have taken one? So that, and sometimes there are cleft details, so there might be a traced information, but there won't be the cleft itself. Okay, but you will have enough information with which to make a decision on that case. You have 15 minutes with the case. Sounds like a long time. My word, does 15 minutes go quickly when you're under stress. And that's followed by a 15-minute viva. You have 2 examiners, only 1 will viva. We used to split the viva into 2 halves. The problem with that was that if you've got a candidate that's a bit slower, they may have missed their opportunity to talk about something before the next examiner took over. So it gives us the flexibility to move you on to the next section, to try and get your marks, and then move you back to something that you may have missed, to try and help you. We're here to give you the opportunity. It is our job to make sure you have the opportunity to score in each of the areas. Okay? So one examiner works really, really well, and the other examiner, you will see will be going writing away, okay? And don't worry, don't look over to see what they're writing. They're just writing to say what was covered during the exam. That means if I'm examining you, I don't have to look away from you. I can keep eye contact and I can keep that communication going. And I'm reliant on my examiner colleague to fill in that detail. So only one person fills in the detail. There has been talk from the college of having one examiner, and we are dead against that. And I think for you as candidates, it's reassuring that there is always some checks and balances. Occasionally, if we see a difference in marks and we mark separately, but if I gave the top mark and somebody gave all the bottom mark, we would then look and say, why have you done that? Oh, they didn't answer the question on Openfire. And I would say, they did. I heard them. So we can modify that mark. So it's really important for us to have people. Why have we disappeared? What's going on? Oh, there we go. So both will mark. So you'll get 2 sets of marks, but only one person will ask. Okay? I think that is better. It helps build a rapport with the examiners. We have a huge case bank. Okay? There are lots and lots of cases, and we pretty much use new cases for every diet. So while you can ask your colleagues what did you have last time, at the moment we're using a new case for every single diet. Each case has a full side of A4 guidance for examiners. So before you've come in the morning, we have an examiners meeting. We look at the case, we have guidance notes. We pick up the key features that we expect you to know in the diagnosis, the radiographs, and we try and highlight the areas that we think a failing candidate might miss out. Okay, so we standardise how we approach and how we mark those cases. So be reassured, we don't just walk in and go, yeah, and we only have 15 minutes with the case. We don't have 2 hours to look at it. So it's really fair that we only have the same time as you. Yes, we've got years more experience. However, if we start arguing about a case, that tells us, look, there are lots of ways of treating this, and it's about the justification from the candidate. So the standard setting is really important to us. Clearly, we want to know if people miss out certain key features that would be dangerous and unsafe for the patient, they're the fail points, and we agree that beforehand. And it's not about a gold standard plan. Most of these cases have 2, 3 or 4 plans that may be possible in there. There are ones that we think are more appropriate and that would be easier and maybe more pragmatic for patients. But if your plan is workable and is on our crib sheet, occasionally the candidate comes up with a plan and we go, ooh, that was a good plan, we'll add that to the sheet. So again, in the old days, I would bring my own case and I know how I treated it, so I'd put it on the table and you would think, oh, I treated it a much different way, that's not a good plan. That is not how the examiners look. There is no one plan. And if it's a sensible plan that would be workable, it may not be the plan that I would do, but if it would work, you would still ask. Okay? Hopefully you're reassured by that. And everybody gets the same. Okay? So that's why we need to quarantine you. So please do not badger our staff about quarantine. You know about that now. If you want to sit this exam, you accept that it is a high stakes exam. That security is really important, so it is fair to everyone. I'm sure you would be really unhappy if you said, well, my colleague, he knew all about that case before he came in. You passed him, you haven't passed me. That would be completely unfair. So it's really important the security of our material is maintained. If you want to find out a case, this information is on our college website. We have test cases for you to have a look at. So when you go and have a look at them, don't look at them in detail. Use them as cases to test yourselves and give you an idea of what you will see on the paper. So if you go into the exam regulations information, you can see the membership in orthodontics diagnostic records example. So you can download that PDF, you can see the format that you would receive. So it will be familiar to you when you use the exam. But again, I would use that as a diagnostic test. So don't just look at it in a timed fashion and get somebody to test you on it. There is lots more information on there. We've got suspected malpractice, what we would do if we found that candidates weren't being appropriate. There's information and advice to candidates. There is lots of info that you can download as PDFs. Again, 3 sections to mark. We used to have 5 sections, we've reduced it to 3. The first section is really say what you see. Here's the face, here's the intraoral. Tell us about the information that you gleaned from those records. That should relax you, because that's straightforward to describing things. what we didn't want is giving you lots of marks here, but then you kill the patient with your treatment plan. Yeah, it's really important that the safety of your care for this patient is based on the second part. So hopefully that will be a comfortable start of 10. You'll have appraisal of diagnostic features, intraoral, extraoral, and radiographs, appropriate radiographs. Then we will move on to, so probably just before the bowel, which is halfway, 7.5 minutes a bowel goes off. You know, occasionally the candidate hears the bowel and no, that's 7.5 minutes. That's just to show us as examiners how we need to progress through the exam and show you that you're around halfway through. You're nearly there. The second half will start just before or just after the bowel, and that's to talk about the aims and objectives of the treatment. What do you want to achieve for this patient, and how do you think you might achieve it? Particularly thinking about your anchorage management, and your anchorage management in all three planes. So not only have you assessed the case, you've seen where the difficult features are, maybe a problem list, some examiners ask for a problem list, some ask for aims and objectives. And then how you might achieve your anchorage reinforcement, and if we have time, a bit about mechanics. But if you don't get into the detailed mechanics that your colleague did, that doesn't mean you have failed, because that's not the detailed part of the exam. They're probably earning maybe some extra marks higher up. So, when you're doing these cases, stick to first principles. A lot of the questions we will ask you are basic questions, and sometimes they're so basic that we ask them, the candidate's like, is he really asking me whether this is class 2 or class 3? Yeah. We want to get the basics right first. The foundations are broad and simple. We will get more and more complicated. So we want to know, can you assess the patient like you would do every new patient clinic? All your cases will be camouflage or growth modification. They will not be surgical cases. Okay? Surgical cases is for advanced training. It is not within the first 3-year curriculum. However, you will have borderline cases. Borderline cases that you might say, well, if the patient had significant facial concerns, I might do some treatment now, but I would also warn them about the possibility of orthognathic. But that's where the conversation would stop. We would recognise that you've spotted that it's borderline. But if you say, oh, the patient is 13 and they're class 3, I would wait for 3 years while they grow. Guess what I'm going to tell you? Right, 3 years later they look like this, how are you going to treat it? So don't sit there with no plan because you thought, oh, this is too early to treat this patient. By all means tell me, I would be concerned by growth here, but if they have no facial concerns, I think this is probably camouflageable, but I would be worried in the retention maybe that the patient could outgrow. Start with the lower arch, don't hop about, systematic treatment plan. We treatment plan all orthodontic cases from the lower arch first, and we build our upper arch to fit. So we will start with the lower arch. So if you start to say, all your mechanics in the upper arch, I'm thinking, well, hang on a minute, we don't even know what you're doing in the lower. So start with your lower arch and decide whether you're going to extract or not, and what the effect of that extraction pattern will be. Now, if you take out lower fours, you're going to have movement distally of your canines. That's going to make your anchorage value in the upper arch more difficult if it's class 2, maybe better if it's class 3. So you need to know the effect of what your lower arch does to decide how your upper arch anchorage is going to be managed and how it might fit together. And then you can decide, actually, do I need distal movements as well in my upper, or do I need 5 because it's a class 3 case and I'm bringing models forwards? You're always going to assume that whatever you give the patient, they're going to wear. So if you said headgear, initially we might say, okay, they're wearing the headgear well. Then we might say, okay, what if they come back and your tag has fallen out, or your headgear isn't being worn? What might you do then? So you do need to think about alternative anchorage strategies for anchorage that may not be 100% with all patients. And the top marks come from supporting. I think I only gave a few top marks this week. If we've got a really good candidate and you haven't given us evidence, we will often ask you, so is there any research or literature that's looked at that? And a name and a date isn't enough. Little word 1992 or little word the any year science produces lots of papers isn't enough. Yeah, oh yeah, they looked at a study where they looked at the failure rates of bonded retainers sort of twist flex versus flex step, and they found actually flex step was slightly better even than the new CAD-CAM nitrile wires. So a little bit of explanation of the paper. So you won't get top marks for just saying name and date. There has to be a little bit of information on that paper. Practice, practice, practice. You cannot do enough of these cases. In the last year of their training, my training is probably about 50 timed cases with about 10 different consultants from a wide geographic area with lots of different cases. So you cannot do enough of these. Your final year of training, you should be doing at least 2 or 3 of these a week if you can. You need to badger people to get them done. Common mistakes, not reading the history. Yeah, we had somebody this week who clearly didn't read that the upper incisors were traumatised. So very clearly in the history, upper left one, traumatised and restored. And it was described as MIH. Okay, so the information's in the history. We will often try and steer you back. Well, what did you think about that tooth? Was there any information in there? I'm not going to bring the paper over. It is your job to read the history. So if it was a patient in the chair, you would ask them about that at the start of the treatment. Too much. So when I ask for a 3-line summary, it means 3 lines. Yeah, it doesn't mean there was a 2-degree rotation on the 5 and a 4-degree rotation on the 6. That is not a summary. I want to know skeletal pattern and the major issues with the case. So we'll come back to that when we have a look at the case in a moment. Failure points are missing key pathology that would be unsafe. So you've missed a cyst on a tooth or a missing tooth that would completely change your treatment plan. So these are key things, including basic dental information like caries. Okay? So it's really important to pick up the pathology. Do an Eastman correction on your cath. You may not always get asked it, but you can give it as you talk. But if you haven't written that down, and suddenly somebody says, what about the Eastman correction here? Oh, it's not a difficult sum, is it? But when you're going to take off 3 degrees over, so that's fine. You take 30 seconds or more wasting time trying to do a sum in your head that's really simple. Because you're flustered and nervous, it takes you too long. So always do an Eastman correction. You can give it as you talk about the cath. If you get asked it and you haven't, it's there. You don't have to think about it. It's quick to do. And this is really common. I'm going to get class 1 molars, canines and incisors. And then we go, well, you just told me your treatment plan is lower 4s and upper non-extraction. Do you think that's going to meet your aims? So you almost need to know your treatment plan first, then your aims come second. We will ask you your aims first. But if we give the wrong aims, we're often then saying, okay, there's an asymmetric extraction pattern here. You said class 1 molars, but you can get class 2 on one side and class 1 on the other. So it's really important that your aims match your treatment plan. And if we're bringing you back to your aims, you've probably made a mistake. Anchorage in all 3 planes. Everybody thinks about AP anchorage. They forget about the transverse and the vertical. Yeah, particularly in things like canines, that's really important. And recognising difficult anchorage. I would say the biggest mistake that we see here in Cairo is thinking that a class 2 molar relationship can be corrected by class 2 elastics or by extraction of a lower unit. If you take out a 7mm tooth, how much space will you get mesialization of the molar? Half a unit. If you're really, really, really lucky, you cannot correct a full unit class 2 with an extraction in the lower arch and moving the molars mesially. You either have to move the whole mandible mesially with some form of growth modification, or you have to have additional anchorage in your upper arch to correct that class 2. I would say that's the biggest mistake that people tell me. Oh yeah, so you're going to take out lower 5s, yes, to correct that full unit class 2, because they're severely crowded in the upper arch, there's been no movement, and they may think that molar a full unit. It will not happen. So when we're back at you saying again, so you think you can get that molar a full unit? Yes. Well, you can't. Now, I've tried it for 20 years, and I'm pretty sure these guys have not seen it yet. No clear plan, and this is because you haven't spent the time developing a plan. You've been so focused on of a diagnosis. You say, well, you could do this, you could do that. I want to know your plan. It's your patient in the chair today. What would be your favourite plan? We will pin you down to make that decision. So, regular access to seeing new patients. So if you've got friends, you can go and see their clinics, a hospital you can go and view, my registrars, new patient clinic every week, new cases every week, and they treat them almost like a diagnostic. You need to see lots of variety of clinical information. It's quite clear this week people haven't seen complicated things like impacted teeth, so you need to know where those cases are going and try and see them as new patients. So regular short case practice, I can't state that enough. Test each other, but it must be timed. Set a clock, set 7.5 minutes if you want, and another 7.5 minutes. But unless you time yourself, you will go over with your diagnosis. That allows you to develop a systematic pattern, and your notes will always be the same. And actually, during the exam, you probably won't use your notes. We always ask for the notes, again, to keep the information secure. And a couple of candidates said, I don't need my notes, it's in my head. And that shows a well-prepared candidate because they're using the information and it's structured in your head. But I find writing things down commits it to my memory better. So you may not use your piece of paper, but it feels comfortable having it there when you're being diagnosed. Yeah? And it's really important you spend half the time on diagnosis, you must spend half the time on your plan. Because actually, 2/3 of your marks are going to come from your plan. So if you waste 10 minutes on the diagnosis and only 5 minutes on your plan, you've got that wrong. And the more cases you do, the quicker you can do the diagnosis, and that leaves you time to think about your anchorage and your plan. Please practice in English. Like I said, we understand that it's your second language, but the better fluency. Yeah, there are lots of vibes going on at the same time, so speak clearly. You have to shout at the examiner, but you do need to be heard. Yeah, we had a few candidates that we were craning to listen to, and the talking about this head up, talking to you, smiling at the examiner. Yeah, are you scared? We know you're nervous, but smile at the examiner. So let's have a look at a case together. It's a case I treated, and I won.
John, can I just interject? Can I ask you not to video this bit with patient information?
Yeah, we can't have patients.
Can we just put the cameras down on your lap, please? And